Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can thrive, be profitable, and successful for years to come. This week on the Edge Podcast, I'm excited to have fellow NSCHBC members, Sonda Kunzi, I'll say it right, a healthcare consultant and educator out of Ohio with team members in Connecticut, Pennsylvania, New York, and Kentucky. She specializes in community behavioral health, redesign documentation, and coding rules. So great topic today, and which leads me into our podcast topic that many of our listeners have inquired about, and also I've been looking to maybe get into the behavioral health and mental health space. So this is going to be a good topic today. Sonda, welcome to the podcast.
Oh, it's great to be here, Terry, and thanks for having me on. This is definitely a subject matter that's near and dear to my heart. I just love the specialty. I mean, if you brought me cardiology, I'd say no, thank you. Behavioral health is where it's at for me.
You'd say, Terry, you're going to stay in your lane, I'll stay in mine. So yeah, because that's one of my top specialties.
Yep.
Those behavioral health and mental health services, it's really been interesting because, as you know, and you and I have been in healthcare a long time. I would say 20 years ago, even, they just weren't covered. I mean, if somebody comes in with, depression or anxiety, we'd be like, okay, what else do you have? So that we didn't even have to pull the diagnosis. But I've noticed, and I don't know if the pandemic hit, basically a mental health kind of wall where I've noticed now a lot more coverages in the behavioral health, mental health space. It's also been expanded like nothing I've ever seen before.
Oh, I totally agree. I think, back in the day, and yes, I've been in the business 35 years as well.
Me too. Yeah.
I hate to say it out loud, but it's the truth.
Me too.
We used to think about, exactly what you said. Do you have another diagnosis, or really, if you say depression, you're going to be limited. They're not going to pay as much. This could, it definitely has made some changes. And I think COVID itself maybe has catapulted that for sure.
I think it did too. And it also kind of expanded into telehealth. They made some permanent changes to coverage that's only for behavioral health. So I thought, and actually it kind of makes me, I'm actually conflicted. I'm very happy that they're finally recognizing behavioral health and mental health conditions and issues. But as you and I know, when we expand coverages and when they don't put in enough guardrails, we get bad actors. So I wanted to chat today about some of the proposed Medicare final rule and fee schedule for 2024 issues. And I'm just a little confused about, again, where the specifics, where the guardrails, where the oversight is on some of the policies. So let me get started with, first of all, it looks like there's possibly going to be coverage, and I mean payments, for a marriage and family therapist, or MFT. But that's surprising to me because as we see all these different, and I'm air quoting, licensed mental health care providers. I don't even see them really allowing for licensed, clinical social workers sometimes, or independent social workers. So can you kind of speak to what you're thinking on some of the things they're adding to this pie that we really don't have a lot more slivers to hand out, and I'm kind of concerned about it.
Yeah, I am super concerned, mainly because the mental health professionals as it stands is like alphabet soup. So what I mean by this is you could be licensed in one state and then the other state has a very similar acronym for a certain type of licensure, but may not be the same. It may not be the same schooling or certification or a number of hours. I think that I need everyone to really keep their eyes peeled for when November comes around, because I think you and I are both going to be surprised at where they're going with this, being that generally speaking, they've even called it, counseling social worker, and really inevitably they've only ever allowed licensed independent social workers on Medicare.
Right.
And really, I know you probably know this as much as I do, that it's been the LPCCs, or the professional counselors, who have been fighting to come aboard even as an independent licensure.
Oh man. Well, my concern too is that, so from what I read, and you're the professional on this, you're the expert. I'm really getting my feet wet in the last few years on this, so I'll kind of defer to you. But it seems like there's six core mental health professionals. There's the clinical social worker, the clinical psychologist, the psychiatrist, professional clinical counselors, as you mentioned, which I mean that just is a disarray of who knows, and then psychiatric nurse specialists. Seems like those
Mhm.
are kind of in that realm. But then again, you get this, I hate to call it generic, but you get the generic, licensed independent counselor, licensed independent social worker. And those are very similar to the clinical social worker, that one particular. But I'm worried about, I guess I'm concerned about some of the independent, if you will, um, clinicians, and let's just call them that because that's what I think what they're referring them to, that are going to be empowered to provide and get paid for care independently. But I'm not even seeing supervision requirements for by medical practitioners who also have a license in mental health, or what the patients, they didn't even put diagnosis oversight out there.
Right.
And I get that this, is a Medicare thing we're talking about, and we'll see how the commercial plans follow. But I worry for the elderly that this could be opened up to the point where you don't have somebody qualified providing the service. And I guess being qualified is subjective, which it should be more objective.
Oh, I really agree with that. And I think that when we first saw the, flash news or news flash come out from Medicare, CMS, we were like,
You
wait,
and I
what?
both were like, what? Yeah.
They're what are they calling mental health counselors? What are they considered? And really
Yeah,
they don't define it. They
they
don't
don't.
get deeper for us as far as that's this or that. They may tell you that they have to be a master's or doctorate and they can, have some type of licensures, but I really want to stress that every state is different, and doing business in different states for behavioral health, even I have to learn new acronyms every time a new state comes aboard as a billing client or even a consulting client okay, well, wait a minute. What kind of licensure is that? How many, what kind of services? And I think that one of the things here in Ohio that just makes me really pause about this is that our Medicaid, right, different than Medicare, but our
Yes.
Medicaid recognizes so many levels of these providers. And because CMS put out their notice, many of those Medicaid providers just thought this was going to be an open door for all their clinicians, and it's
Yeah.
not.
Well, we have the same thing here in California. And the one thing that I was concerned with is now have clients, medical doctors and DOs and nurse practitioners and PAs that are all saying, well, I don't specifically have mental health experience, but since I can bill directly to, I can't even say it without being amused a little bit, but I can bill directly to Medicare or to the payer. I'm qualified, right? And I don't have an answer for them. I'm thinking now I have to look at best practices or common sense even. Well, if you don't have experience in that, I mean, it almost reminds me of the fact that, I'm a certified coder times who knows how many, I've got all the alphabet soup.
Right.
But I don't do, like, for example, somebody asked me the other day something, and I don't even remember what it was, but it was just a specialty that I don't do. And I'm just like, that's not my specialty, but thanks for playing. I think it was labs. And
Ah, yeah.
they were just like, but you're a coder. I go, yeah, I'm a coder, but I'm also very specialized and I stay in my lane. But I see that because reimbursements are going down and because people are trying to find these, and I don't like to call them side hustles in healthcare, but let's say revenue opportunities, even though you and I
There you
both
go.
know it's a side hustle.
It's a side hustle. Yeah.
Yeah. I feel like you said, the open door and just expanding things. And here's something that's really scary. I was talking to one of our fellow members, a really good friend of mine, Christine Hall,
Yeah.
who dabbles in this too. And her and I were chatting, and she was saying, her and I were actually on another podcast, and she was saying that during a well-check visit for a child, something was mentioned about the child saying, "Yeah, I don't really like my math teacher." But we're working through that. I got a tutor and I'm figuring it out. Well, then the doctor actually put there that the patient was depressed due to some social determinant of health of not being able to focus in school. And the mother's
Oh
like,
my
we
goodness.
never said that. We don't want him labeled. We never said that. He just said that he doesn't like his math teacher. So to me, again, without having specific guardrails and, black and white of this is how you do it, where do you see this heading, Sonda? It makes me very nervous.
I completely nervous, and guardrails is really a good word because in this business, if they're not there, somebody's going over. Um, it's just a problem for me because even the struggle here when we have these lower level, and I don't even like to use lower level, okay, just it's kind of just the way we see it because we're looking like this licensure can do this licensure can do that, and on my
Right,
arm here
right.
I'm going all the way down.
Physicians, mid-levels, and then you go under that, right?
But there
Clinician,
are
right?
state guidelines on some of these folks where you look at them and it literally says cannot diagnose.
Oh,
So
okay.
that's going to be a challenge.
Okay. Okay. So that actually, almost falls with some of the ambiguity we see with medical assistants. Every state is different. And I
Correct.
see, you were amused. You're like, "Oh yeah, I deal with that too." But cannot diagnose is probably that should be a bumper sticker.
Yeah.
It if you don't have, ability to diagnose and make medical decisions independently, then
Yeah.
maybe you have to look at this differently. But I could just see this going down a rabbit hole that, I mean, what in a weird way. So I wanted to clarify with our listeners, if you are truly a mental health professional, if you're truly a behavioral health professional, you know, Sonda specifically, since this is what she specializes in, setting you up with, the coding rules and how to provide this in your practice, we want you to be able to do it. But
Right.
our concern is that a lot of providers, physicians will say, are looking to hire very inexpensive staff to take over this very important carve out of healthcare. And if we're really going to embrace mental health and the behavioral health services, it really should be with, clinicians and healthcare professionals who actually have the schooling, the education, the background, the experience to do that, and not just saying, well, we're going to just give them a 2 hour class in our office and
Yeah.
then we'll make up some kind of credential and, certificate. And that's what worries me because I don't find anything that says they couldn't do that.
Yeah, I don't either. And I again, when they wrote in, like, I think it was the frequently asked questions, they say license or certification, which is
Oh,
really scaring me.
oh my goodness. Oh my goodness. I can give a certification for training something on somebody. Wow.
Yeah.
Wow.
And I think you're right. I think that, look, we all are looking to save money in healthcare in terms of bringing on staff, but you still have to bring on the right staff, and you could really be hurting patients if you don't get somebody who is trained. And again, we're not saying anything against those who are aspiring, in the field, just new and want to see this go through. It's you just have to have experience. It's as if, like, you would not want me coding cardiology.
Well,
I need experience,
you
and it's
need
going to take a
experience,
while.
right? Well, I mean, to me, it reminds me of when the pandemic started and everybody, and I mean, I've been teaching
Mm,
telehealth for 20 years, but prior to the pandemic, it was like pulling teeth trying to get any providers on board, even ones in rural areas. And then as soon as the pandemic hit, oh my gosh, my phone lines were flooded, emails were flooded. Terry, help us, help us. I'm like, okay, okay, we'll get it done. But I just remember getting this one provider. You'll get where I'm going with this. That called me and said, "Okay, so how can I set up for telehealth?" And I said, "Well, what kind of provider are you?" And she said, "I'm an acupuncturist."
oh, I'm sorry. I
And
had to
I
laugh at
went,
that. Oh,
"What?" So
put
I thought
the
somebody was punking
needle
me.
in your, yeah. Place the needle just one
Yeah. I'm like,
centimeter.
how do you do that over? She goes, "Well, I
Mhm.
can set up where an audio and video." I'm like, "No, you need to call somebody else because that's not going to happen."
Yeah.
So that's what this kind of reminds me of in a way, only because again, I don't see the clear guidelines, and I believe that every provider really wants to do what's right and what's
Mhm.
appropriate, but they look for these guidelines. I even have doctors saying, "Well, tell me where it says I can't do that, and that's hard to
Yeah.
find. But I think the one thing that's helpful, and I'm not sure you've seen this, in screening for behavioral health services,
Mm.
if
Hmm.
a doctor find something, and the patient doesn't even have to have a diagnosis, but if they find something, it says if they have to follow up with that transfer to an actual professional that has the background in mental health services. It seems like Medicare at least closed that loophole. It can't just be,
Yeah.
sending them over to anybody.
Yeah. And, just as a side note, I was working with a group in Pennsylvania, and a carrier in Pennsylvania was actually telling them they had to do this. This was like a big deal. And I'm sure this is like, you got to do a depression screening on everybody who comes in.
Oh,
That
geez.
was what they were saying, which really wasn't, they were saying that more of it was like a gut check. Like if you
Yeah.
really feel like your patient is saying something to you and you want to screen them, that would be the most appropriate time. But in obviously when I was auditing, I said, how come there is a procedure code, and I'm going to say GO 444 for everybody, that's a depression screening
Right.
on every patient? Well, the insurance carrier told us we have to.
Oh my
And
gosh.
as you can imagine, after unpacking that, that wasn't the actual story, but even that screening piece had to be reined in, where we were like, this is just one code that got out of hand.
Yeah, well, and I was reading, I know this is you're gonna find this unbelievable, but nowadays nothing surprises me. I was auditing a record recently, and the patient, I guess, was heavy into fantasy football, and
Mm.
they kept losing every week, so their depression level was really high. And I'm like, what?
Mine would be too.
I know. And so they basically put depression in their record. The other one was the patient no longer could get DoorDash delivered from her favorite restaurant. I know, I'm face planning too, Sonda. And
Mm.
the doctor said, try to put that in as a depression. I'm like, people, common sense has to take over here at some
Yeah.
point. Look at what depression definition is. That's not it. That's having a
Right.
disappointment, but that's not depression. And trying to talk the doctors out of that is really tough. And when I explain to them, okay, when you have, for example, the pandemic, and somebody that was now forced to be shut in, and now they're afraid to go out because, let's face it, social media and a lot of the propaganda against certain vaccines, certain things, or certain viruses, whatever, is
Mhm.
they're up there to kind of cause fear. And,
Right.
even for patients who aren't compromised, which is a bummer. And so, yes, when you get that kind of conversation and you have to kind of walk the patient back from the ledge, yes, that's absolutely something that you could, document well, that could be on the verge of that. But when you start to get silly and add things that are activities of daily living that they're just not, able to do, it just, I get nervous, because now it seems like everything the patient says to the provider is going to be under the behavioral health or mental health, and the pie is not that big, and I just feel
Right.
like it's going to pull resources, pull reimbursement, when it's just not there, and I get nervous about that, especially because of the expansion into telehealth, where the patient then doesn't even have to come in.
Yeah.
So, you know,
That's hard to take.
well, yeah, because now you're not even looking at their demeanor,
Hmm.
are they focusing? Are they just looking at their phone? Or, and again, I'm not a healthcare, behavioral health, clinician. Used to be a nurse, but not in that field. But as a former clinician, I do recognize where there has to be a fine line somewhere that isn't overstepped. So I have a question to you, because I know sometimes I going to go off on a tangent. How do you set this up for, I noticed on your website that you specialize in setting up these community behavioral health, and I think you call it redesign, and you show them what the documentation has to look like, the coding rules. Where do you start if somebody wanted to open the door to this specialty?
I think that you have to start with who they're going to serve and what their thought process is in that. Are you going to see Medicare patients? Are you going to see Medicaid? Are you going to have commercial? Who's going to be working who's going to be designing this clinical program. I mean, with some of the groups that we have, which is kind of interesting too to talk about real quick, is that we're having where things that were normally done in the hospital are now being done in freestanding facilities for substance use disorder, in addiction medicine. It's really opened up the door on who can provide what service and making sure that they're getting accredited or certified in their state. So again, understanding who they're going to serve. If they say, well, this is only going to be for mental health, for depression, anxiety, or whatever, or they're saying we'd like to take care. Usually we're finding out a lot of some pop-ups for addiction medicine. Good. Listen, there's good and bad and everything, but there are people who are on a mission who may be sober 10 years, but want to now have been back to school and want to open a facility and maybe don't even know all the rules. And in our state, there is a special certification. And now I'm happy to say, and I know people in this state aren't necessarily going to agree with this, is that along with that state certification, they're requiring Joint Commission or CARF or OAC. So they're attaching a national accreditation board to it. Yeah. It was only the local board and giving a certification, and now they're marrying that. And I feel like that was a really good move to say, we're going to make sure that everybody is set up right, is doing the right thing, and is approaching the patient from a clinical perspective. I myself, again, like you, I'm not even a nurse, but or have been a nurse, but I'm not clinically driven. So I just have to understand their business operation look, their mission. How can I make their mission work for them if they truly want to help the patient? And then our company doesn't do credentialing, but I know a lot of good credentialers, and it depends on what you're looking for and what, again, the licensure level and who you're going to bring in. And we're able to say you can't bring in that level of service, or that person can't see your commercial patients, but they can take care of your Medicaid. And maybe they can in this state, but not that state. So it takes a lot of research on my part too. If somebody's going to call me from Oklahoma, I may not know the rules, and I'm going to have to go look.
Right. Well, so it sounds like what you specialize in is really setting them up with almost a business plan, if you will, of how to get this started, how to implement the rules for coding, the rules for reimbursement, documentation, and then you have partnerships to be able to do, who has to set them up with credentialing and then accessing those payers, which is awesome because, and I want to make sure our listeners know, Sonda and I really believe that it's an important carve out of healthcare. It is. Totally. And the fact that, I'm very appreciative of the fact that the payers are starting to recognize behavioral health and mental health. It's the commercial plans realize that it's kind of a reimbursement. I hate to say this, but it really definitely pulls from their profit margin. So they're not quite as expansive as Medicare and Medicaid. And in our state too, Medicaid is all over this. They really believe that the lower income people who qualify for Medicaid really can benefit from this. And I think for the most part, I would say probably 80%, I think it's appropriate. Yeah. But you do have the bad actors. You do have the, where somebody doesn't have a specific payable diagnosis. They're like, oh, but if I use this, I can get you, services, which is bad.
Very bad.
Yeah. But I think that, just kind of giving some advice to anybody trying to get into this space, I think it's important, first of all, Sonda, you made a great point. Instead of who is your audience, who is your patient population that you're trying to address, that you're trying to target, right? So that's the first thing. And then what staff members do they have, or are they thinking of hiring? And what kind of background or certification or credentialing or licensure do they have? Is that the next thing?
Yeah, for sure. They have to understand, again, state to state's going to be a little bit different as we get into, mental health and addiction. It's a little bit different than saying, like, we're so used to being able to see, well, you need an MD or DO or CNP or PA and all those acronyms that I'm saying, but, a certified nurse practitioner, a PA, or a physician, right, are things we're just typically used to and understand the rules and are kind of like almost nationally accepted, even though, they're different state to state licensure, and that's too long to get into that whole scenario. But when you get down to the mental health providers, this becomes more of an alphabet soup than we've ever been used to. And it takes time to understand which each state allows, what they call them. They might call them in the addiction world, they might call them a licensed chemical addiction counselor. They might call them a certified addiction counselor. I mean, that's even in another realm. It's interesting to know what the mental health providers are, but now we have even different levels of substance use. And there's a lot of question out there whether Medicare will address that. And I haven't seen anything just yet.
Okay. And then when we get into the licensed independent social worker or clinical social worker, is that more about social determinants of health? I was just trying to figure out what their services would be covered.
No, I mean, the licensed independent social worker is typically doing psychotherapy.
Okay.
For Medicare, it's typically there's got to be a physician order for it to happen. So I mean, we're still having a referral base, although you can hang up your own shingle and again, all the rules of the commercial carriers are going to be a little bit different on how you have to sometimes, again, having the right electronic medical record is key. In the state of Pennsylvania, we found out that it was very difficult changing this one client's electronic medical record because it couldn't do what the state required in the treatment plan.
Oh.
So, I mean, there are so many variables with who looks at the treatment plan. And you know how we say every E&M must stand alone, and E&M meaning evaluation and management for those who don't know that term, and that you don't look at the chart, you don't send the chart. Consequently, when someone's providing therapy, typically the carriers will want the first assessment that decided where the therapy was needed and creating that. They'll want to see the treatment plan, and then they'll want to see the individual services, whatever dates they're looking for. So there's a little bit more to it than just send the psychotherapy note.
Well, and you just brought up something on E&M services. Remember, listeners, most of these services are not E&Ms. They're therapy, right. They're therapy codes, they're specific codes to mental health, they are behavioral health screenings. So if you're thinking these are office visits, think again. These professionals with all the different acronyms, though, they cannot bill directly for E&M services. That sticks with MDDO and mid-level providers, nurse practitioners, PA. So, and they may not be able to if they don't have, certain education when it comes to mental health. I know some payers are like, no, you don't even do that. But try to stay away from the E&M services. But, one of the things, just to wrap this up, I think the first thing, I should say the final thing I want to tell the listeners, before you jump into anything, do your due diligence, find somebody like Sonda that understands what you need to do to at least even start the process, and make sure that you're not just saying somebody told you. I always get that from practices. Well, we were told, and we're like, who told you that? And then they don't know who told them that. Another doctor down the street's doing this, so I'm going to do it.
That
They're
line.
getting paid. Yeah. And I'm like, just because you get paid doesn't mean they can't take it back. But if you truly have a patient population where you're located that really could benefit from mental and behavioral health services, then by all means, really start to do your due diligence to see if it's appropriate. Also, we should let you know, Sonda and I are working on a project for next year, a virtual health behavioral health summit, and it's going to be in webinar form, so you'll have a little bit more, paperwork to be able to reference. So take a look at that for next fall. So we're excited about that.
Completely excited about that. It will be so fun teaming up to do that and getting everybody together to talk about behavioral health and giving, the audience a little bit more information.
Yeah, no, I'm excited about that. Well, Sonda, thank you so much for being our subject matter expert and our guest today on the podcast.
Thank you. Loved being here. Loved the subject. It was fun for me.
So this topic could not come at a better time with the Medicare final rule proposal that did expand behavioral and mental health services for 2024, and we all need to be clear on what will be covered so that we don't burden patients with bills they won't be expecting, because you never know what could be non-covered. So we definitely appreciate Sonda's time and her insights on this. So to contact Sonda Kunzi, go directly to the NSCHBC.org website, and click on Find a Consultant tab and type in Sonda, S-O-N-D-A. I keep calling her Sondi. Maybe it's my nickname for her, but it's S-O-N-D-A in the first name field, or Kunzi, K-U-N-Z-I in the last name field, and you'll have her direct contact information. Also, as a reminder, the NSCHBC.org website offers monthly free webinars on a variety of topics, as well as the quarterly Medicare regulatory update. Please go to the NSCHBC.org, click on the tab for upcoming education. Our next Medicare update is Tuesday, December 19th, and that is presented by yours truly, Terry Fletcher. That's it for us today. Everyone, make it a great day, a great rest of your month, and thank you for listening to this NSCHBC Edge podcast.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.